Yeah, madam, we are online now.
Okay.
Dr. Someshwar, sir?
Yeah, Venkatesh.
Yes,
I
sir.
will
Now it is on live, so we can start the session, sir.
Okay. Yeah, fine.
Slides are there.
It is there, madam. The start screen is there, no, madam. It will come. Once the introduction was over, it should come.
Yeah. So we are starting, ma'am.
Yeah.
Good evening, doctors. This is Dr. Someshwar from Shield Healthcare. I welcome you all on behalf of Shield. Thank you very much for joining today's webinar. I request all the participants to post their questions in the comment box given in the below so that the doctor will address at the end of the webinar. And thank you once again for joining today's webinar. And I welcome today's our speaker, Dr.Sushma ma'am. It's my honor to introduce you, ma'am. Actually, madam doesn't need any introduction. She's very known for, apart from her specification, she is known for her kind-heartedness. And Dr.M.Sushma ma'am, Madan Mohan, she completed medicine, DGO, CMP, and she's a senior gynecologist, consultant gynecologist and menopause specialist practicing in Kukatpalli since 20 years and working at Sri Rama Clinic, Lucid Diagnostic, and visiting consultant at Rainbow Hospital, Hydernagar, Hyderabad. Thank you, ma'am, for joining today's webinar. Ma'am, before proceeding to the webinar, we have Shield Digital Connect, which is where we are going to take today's webinar. So this is a Shield web page, digital web page, where we are trying to connect all the doctors at one platform through scientific related information with webinars, blogs, and also the interesting patient awareness programs. So here we have a blogs page. And also we have GDM gestational diabetes web page where we have awareness videos regarding GDM management and also as well as the patient education. And also we have webinars page where you can see the past and upcoming webinars. And we have a leaders page, and there you can find today's speaker, Dr.M.Sushma Madan Mohan ma'am, regarding whereabout, and also you can find the webinars taken by her. And Shield Connect strives to improve the patient awareness as well as the patient wellness by not only with the products, also by through scientific innovation. And thank you. I request all the delegates to please do visit Shield Connect webpage. Thank you, ma'am. And over to you for the presentation.
Hello. Good
Yes,
evening
ma'am.
to all participants of today's Shield Connect webinar. This Shield Connect is an excellent platform to upgrade our scientific knowledge. I thank Dr. Someshwar, Mr. Pandurang Rao of Shield Connect team for giving me this opportunity. Cheers. Yeah, I'll start. Now, today's topic is management of menopause. It's not moving. Yeah. So, about menopause. Menopause is a normal natural event defined as a final menstrual period confirmed after 1 year of no menstrual bleeding. It represents as a permanent cessation of menses resulting from loss of ovarian follicular function, usually due to the aging. Am I audible? Am I audible?
Yes, madam.
Yes, madam. Yes, madam. Yeah.
Okay. So here, the natural age of menopause mentioned 51 years, but in Indian scenario, our average age of menopause is 46.7 years. Prematurely, from medical intervention also menopause is because of bilateral oophorectomy, chemotherapy at any time from impaired ovarian function. The premature ovarian failure is also another reason for the menopause. The prevalence of menopause in India. The Indian population approximately of 135 crores. Out of that, 48.19% is shared by the female population, that is approximately around 65 crores. And out of that, 11% women are fall in between 40 to 60 years. So approximately 7.5 crores female fall in between age of 40 to 60 years. Hence, there is a huge scope of perimenopause, menopause, and postmenopause. The terminology is a straw staging system. Here is the stages of reproductive aging workshop. The lifespan of the women is divided into the different stages like reproductive phase, menopause transition, and postmenopause. In the reproductive phase, stage is given as a -5, -4, -3, while menopause transition is given stage -2, -1. Here 0 is a final menstrual period, +1 and +2 is a postmenopause. In the reproductive age, menstrual cycles may be regular or variable with normal FSH or increased FSH. In the menopause transition, the menstrual cycles may be having variable or amenorrhea, where there is increased FSH and decreased AMH. While postmenopause status, there are no menstrual cycle, no menstrual bleeding, and increased FSH and decreased AMH. Normally, to diagnose menopause, we say FSH level more than 40 is a diagnostic of menopause. But here, we don't do FSH test for each and every female or women for the diagnosis of the menopause. Age at the menopause has remained constant while life expectancy has increased. Around 1940s, the life expectancy of women was around 30 to 40 years. Now presently it's around 60 years, and by 2030 that may be around 68 years. There are certain changes happen in the menopause, especially in the hormone levels. The decreased circulating estrogen, because menopause is characterized by deprivation of the estrogen. So there is a decreased circulating estrogens, decreased ratio of estrogen and androgen, decreased sex hormone binding globulin secretion, increased peripheral aromatization of DHEA to estrone, reversal of estradiol to estrone ratio, but no significant change in testosterone level. The body having estrogen receptors in almost all the parts. For example, it's in the brain, breast, eyes, genitourinary system, heart and blood vessels, liver, ovaries, skeleton, skin, and hair. In all these organs, estrogen receptors are present, and in the menopause, because of deficiency of estrogen, the symptoms are present in the form of hot flashes, insomnia, irritability, mood disturbances, dementia. In the eyes, there are macular degenerative changes. In the genitourinary system, there is a vaginal atrophy, stress incontinence, dyspareunia. There is increased incidence of cardiovascular events. The ovaries are deprived of follicles. In the skeletal, the osteoporosis sets in, muscles become weak, skin become atrophied, and hair changes also sets in. The estrogen receptors are alpha and beta, and they are present almost all over the body in almost all the organs, especially in the ovary, CNS, and many other tissues. So estrogen has many complex, beneficial, deleterious effect on the body. Estrogen loss, especially in the menopause, because of estrogen loss. The different symptoms are present in the form of hot flashes, mood swings, sleep disturbances, acute cognitive changes, urogenital symptoms, skin changes, cardiovascular diseases, osteoporosis, cognitive decline, that is Alzheimer's disease. Whenever the female or women suffering or enters in the menopause, first the biggest issue she is suffering with the vasomotor symptoms, and many times the women come to the doctor, especially the gynecologist, for the to get rid of these vasomotor symptoms. They are very much annoying, and this is the window of opportunity where gynecologists have to explain her about the importance of hormone therapy and give her benefit of the hormone therapy. Here, the vasomotor symptoms are present in the form of recurrent transient episodes of flushing accompanied by sensation of warmth to intense heat on the upper body and face. Almost 75% of perimenopause women suffer with this symptom. This is triggered by small increase in core body temperature acting within a reduced thermoneutral zone. Treatment based on symptoms like severity and women's risks and personal attitude about menopause and medication. Here is the pictorial presentation of hot flashes. Here, in the menopause, because of deprived estrogen, the core body temperature increases, increase in skin blood flow and heart rate, intense feeling of heat with reddening of upper body, especially in white population, increased heart rate, it increases skin blood flow and peak sweating, and ultimately it causes chills and shivering. The next most common presentation in the menopause is, or common complaint we can say, is vaginal symptoms. But this is many times patients are shy of explaining or telling this. So we have to ask them the leading question to know about their problem. Here, the vaginal symptoms are present in the form of vaginal dryness, vulvovaginal irritation, itching, dyspareunia. Almost 10 to 40% women are suffering with this. Unlike vasomotor symptoms, which abate over time, vaginal atrophy is typically progressive and unlikely to resolve on its own. It needs treatment. Treatment includes regular sexual activity, lubricants, moisturizers, and local vaginal estrogens. Here, the pictorial presentation of the estrogen effect on the vaginal epithelium. The first picture is showing well-estrogenized premenopause state epithelium, and here the low estrogen postmenopause state. The next problem is patient coming with or women coming with the sexual health. Sexual issues generally increase with the aging, and they are very much distressing, causing sexual complaints are peak during midlife 45 to 64 years. Decreased estrogen causes decline in vaginal lubrication and elasticity. Decreased testosterone may contribute to decline in sexual desire and sensation and active sex life. Lubricants, moisturizers, local vaginal estrogens may help to maintain the vaginal health. IMS recommendation on postmenopause hormone therapy and preventive strategies for midlife health. Here, the indication of hormone therapy, we can say menopause hormone therapy is mainly for relief of menopause symptoms. For the prevention of osteoporosis, to maintain the quality of the life in menopause year, and especially in the women who are suffering with the premature ovarian failure, gonadal dysgenesis, surgical or radiational menopause. The different regimes used in the form of estrogen and progesterone. Estrogen and progesterone are prescribed especially in the postmenopause patients with the uterus. So progesterone here is added especially with the uterus with the patient with the uterus. The second regime is estrogen alone. Estrogen alone is suitable for women who had hysterectomy but Here, those who have undergone subtotal hysterectomy, cervix has been retained, or hysterectomy with the history of endometriosis, in these women, in spite of hysterectomy, we have to add progesterone in this sort of patients. The third route of hormone therapy is vaginal estrogen therapy. It's mainly useful for the patients who had urovaginital symptoms, or especially vaginal dryness. Now, considering the hormone therapy should be the part of overall strategy, including lifestyle recommendations regarding diet, exercise, smoking cessation, safe level of alcohol consumption for maintaining the health and in the menopause and perimenopause women. Hormone therapy should not be recommended without a clear indication for its use, significant symptoms or physical effects of estrogen deficiency, then only we can prescribe hormone therapy. Postmenopause hormone therapy is not a single regime given to standard women. Hormone therapy must be individualized, tailor-made according to symptoms and the need to prevent, as well as personal and family history, results of relevant investigation, and women's preferences and expectation. In the early menopause, when there is a premature ovarian failure or insufficiency, women experiences spontaneous or iatrogenic menopause before 45 age, particularly before 40 years, are at higher risk for cardiovascular diseases, osteoporosis, and may increase risks in the form of the dementia. Use of HRT or hormone therapy may reduce these risks, but the evidences are limited. Duration of therapy. There is no reason to place mandatory limitation of the duration of the hormone therapy. That varies, depends upon the need of the patient and the comorbid conditions. The dosage should be also titrated with the lowest effective dosage. Lowest dose of the hormone therapy is being used previously may reduce the symptoms sufficiently and maintain the quality of the life. The most important part is counseling. Women taking hormone therapy should have given at least annual consultation to include physical examination, update her medical and family history, relevant laboratory and imaging investigation, discussion of lifestyle and strategies to prevent or reduce the chronic diseases. The progesterone, why we add? In general, progesterone should be added in systemic estrogen for all women with uterus to prevent endometrial hypoplasia and cancer. Low dose vaginal estrogen, when administered for the relief of the urogenital atrophy, or they are systemically absorbed, but at very low level, which won't affect the endometrium. Hence, progesterone need not to be added in vaginal estrogens. The progesterone's safety and considerations. About the progesterone component of HRT, there is a more significant increase in breast cancer risks rather than the estrogen. Progestogens and other effects like natural progesterone, some progesterones have specific beneficial effect that could justify their use besides the expected action on the endometrium. The well-documented blood pressure lowering effect of drospirenol also is unknown. Progesterone may not be alike in regard to potential adverse metabolic effect or associated breast cancer risks when combined with long-term estrogen therapy. Androgen therapy here it is mentioned, but it is useful when the woman is suffering with the bilateral oophorectomy, adrenal failure, particularly with the health-related quality of life and sexual dysfunction. Though they are not very freely available in India, the postmenopause osteoporosis is mainly hormone therapy is effective to prevent this. Bone loss associated with the menopause and decrease the incidence of osteoporosis-related fractures, including vertebral and hip fractures, even in women not at high risk of the fractures. Postmenopause osteoporosis in this hormone therapy for sole purpose of prevention of fractures after age of 60 years is not recommended. continuation of hormone therapy after 60 years of age for the purpose of fractures prevention. It should take into account the possible long-term effects of the specific dose and method of administration of hormone therapy compared to other proven non-hormonal therapy. To protect the hormone therapy for bone mineral density declines after cessation of therapy at unpredictable rate, although some degree of fracture protection may remain after cessation of hormone therapy. If patient is still considered at risk of the fracture after cessation of hormone therapy, additional therapy with proven bone sparing medication should be given. Now, what are the risks of the hormone therapy? Normally, if we give appropriately select the patient, give the appropriate doses, monitoring the patients rightly, these risks are very low. The most important risk is endometrial cancer, but we are supplementing progesterone to prevent the endometrial proliferation and cancer. The venous thromboembolism is also one of the known complication or risks in the hormone therapy. It increased risks within 1 to 2 years of initiation of hormone therapy. There's an increased risk of the breast cancer, increased risk of the ovarian cancer, and the increased risk of the cardiovascular accidents. The different medication type are conjugated equine estrogen like a CE, or we can say Primarin, plus medroxyprogesterone or MPA given by the oral route. Evidence for protection against loss of bone mineral density is available for lower than standard doses in oral and transdermal administration. Tibolone is another drug which is a synthetic steroid having affinity towards the estrogen, progesterone, androgen receptors, has proven efficacy against the vertebral and the non-vertebral fractures. Other different types which can be prescribed for the most menopause ladies or menopause women is a SERM, that is the selective estrogen receptor modulators like raloxifene, lasofoxifene. Bazodoxifene reduces the risk of the vertebral fractures in postmenopause women with or without prevalent vertebral fractures. Combination of bazodoxifene and C has been shown to preserve bone mineral density. Now, this is about the hormone therapy. What are the non-hormonal therapy and why do we need? The non-hormonal therapies like calcium, the postmenopause women need 1000 to 1200 milligram of elemental calcium. Calcium supplementation should be restricted to bridge the shortfall between diet intake and DRI, and to patient being treated with high fracture risks. In the osteoporosis, prevention of osteoporosis, vitamin D also plays important role. Daily requirement of vitamin D is 800 to 1000 international units in postmenopause women. Vitamin D supplementation has been shown independently to lower the risk of the fracture and falling in the elderly patient. Many patients ask us the other sources of vitamin D. In that scenario, we can explain them that the sunlight exposure is a good source of vitamin D, provided 20% of the body parts should be exposed for minimum 30 to 40 minutes in between the sun exposure time of 10 a.m. to 2 p.m. I think it's very difficult. The other treatment for the osteoporosis is bisphosphonates. Bisphosphonates are potent inhibitors of bone resorption and decrease the rate of bone turnover with a proven efficacy in prevention of vertebral and hip fracture. A drug-free holiday may be considered after the use of the 3 to 5 years of bisphosphonates therapy in patients with good bone mineral density, response to treatment without prevalent fractures. Bisphosphonates have benefit in some cancers and prevent bone metastasis. The SERMs, that is the selective estrogen receptor modulators like raloxifene, lasofoxifene, bazodoxifene, reduce the risk of the vertebral fracture in postmenopause women with or without prevalent vertebral fracture. Combination of bazodoxifene and C also shown the help to preserve the bone mineral density. Raloxifene is also indicated for reduction of invasive breast cancer in postmenopause women with osteoporosis. Osteoporosis and parathyroid hormone produces significant reduction in risk of the vertebral and non-vertebral fractures by stimulation of bone formation. Here the action is stimulation of bone formation. There is no indication that combining parathormone with bone resorption inhibitors has any additional benefit to giving either drug alone. Prior treatment with bisphosphonates blunts the effect of the subsequent parathormone or parathyroid treatment. PTH may be given for maximum period of 18 months, and that we specially reserve for the severe osteoporosis patient where T-score is more than 2.5, minus 2.5. The strontium is another drug, strontium ranelate, that significantly reduces the risk of the vertebral and non-vertebral fractures in osteoporotic and osteopenic patients, irrespective of presence of fractures or age. The mode of action of strontium ranelate involves stimulation of bone formation as well as inhibit the bone resorption. Now, other drugs for vasomotor symptoms. They are selective serotonin reuptake inhibitors like SSRI, selective non-adrenaline reuptake inhibitors SNRI, and gabapentin are effective in reducing vasomotor symptoms in short-term studies. Their long-term safety need further evaluation. Here, the few medical herbs, they also have active ingredients and shown the promising results. These are like cinnamic acid present in Sanechum 45 milligram, the S-methyl ester present in Flomis ambrosia 41.78 milligram, dicursin and dicursinol angelica gigos 45 milligram. There are few studies which are showing that this gives benefit in the postmenopause or menopause women for protection of the osteoporosis and give the benefit. Here, especially estrogen 100 milligram is prescribed as a 1 BID, which is a non-hormonal treatment, especially useful in the perimenopause, menopause, and postmenopause patients. It regulates estrogen affinity to estrogen receptors. It upregulates the estrogen affinity to estrogen receptors in non-reproductive target organs like vasoendothelium, CNS, and bone. In the vasoendothelium, it reduces hot flushes and night sweats. By acting on CNS, that improves mood swings and insomnia, and on bone, it improves the bone marrow density. At the same time, it downregulates estrogen affinity to estrogen receptors in reproductive target organs, and there is no risk of the cancer. So estrogen is estrogen 100, the medication is a non-estrogenic hormone regulator, which is having no affinity to alpha and beta receptors. Here, the few evidences or the study has been shown that the relief of the symptoms like vaginal dryness, hot flashes, mood swings, bone pain is relieved with the treatment of 7 to 14 days. There are many studies done for the evaluation of the effectiveness and safety of the estrogen 100 in perimenopause patient. These are some pictorial graphical presentation of showing the relief of the symptoms. So ultimately we can say estrogen 100 for 12 weeks, 2 times a day, statistically significantly improve the quality of life. Many symptoms like hot flashes, night sweats, nervousness, vertigo, fatigue, rheumatic pain, vaginal dryness, even recurrent UTI, the symptoms are relieved with the use of this drug. At the same time, we don't found any adverse effects of using the estrogen 100. So we can say that estrogen is a safe, effective herbal formulation for the treatment of menopause. Even at the use of 2 grams per kg body weight, that is not showing any toxicity. Other options for the treatment of the menopause are the healthy lifestyle that includes exercise, that's regular moderate exercise reduces the cardiovascular mortality, better metabolic profile, balance, muscle strength, cognition, quality of life are observed in physically active person. Heart events, stroke, fractures, breast and colon cancers are significantly less frequent. Exercise gives benefit of the to overcome the overweight, and optimal exercise advised is 150 minutes of moderately intense exercise per week with 2 additional weekly sessions of resistance exercise to improve the muscle strength. The recommended intensity of aerobic activity depends upon the patient's fitness. Next, about the dietary advice. The basic component in the diet should be included like fruits, vegetables, grain fibers, fish twice a week, low fat, olive oil is more preferred, consumption of salts to be restricted at 5 milligram, alcohol restriction at 12 gram, and weight loss only up to 5 to 10% can be advised. Now, in the present scenario, in the COVID-19 pandemic, whenever the patient of menopause or postmenopause under treatment of hormone therapy, when diagnosed or confirmed diagnosed of COVID-19, either they are treated in hospital or outpatient, the first step is to stop or withdraw the systemic hormone therapy. The same time, transdermal hormone therapy can be given, but yet study is going on and still we have to conclude about this. So this is regarding the total presentation of the menopause therapy, treatment, hormone treatment. Few important points which we encounter while treating the patient in our OP based. So here important points I'm just telling you about management. In the management of the menopause is a counseling is the most important. Second is a detailed history and examination. Third most important is a screening with the blood test, imaging and other tests. Fourth is a dietary prescription. Fifth is exercise. Sixth is a medical management. And here the role of gynecologist is very important to convince the importance of hormone therapy and give the benefit of hormone therapy to the patient to prevent further cardiovascular accidents, osteoporosis, and other related problems. And another important thing is a follow-up. Now the counseling, what we have to explain her. Explain the women about what is a menopause, why this happened, and what are the changes happening in this menopause phase. Discuss the benefits, risks, side effects of the hormone therapy. What are the different options of hormone therapy to be explained to her? The way of monitoring the hormone therapy, how long it is to be used, we have to explain her, and the expenditure of economics of the hormone therapy, how much money she has to spend on this, and other available options if she is not willing for hormone therapy or if it is not indicated. In the history, we have to take the detailed history of about her age, menstrual history, age of menarche, time of menopause, her obstetric history, contraception, what she's using, and present complaints like vasomotor symptoms, urogenital problems, sexual problems. The other comorbid conditions we have to discuss her about her cardiovascular diseases, metabolic syndromes, diabetes mellitus, thyroid, central nervous system related problems like dementia, Alzheimer's, sleep disturbances, mood swings, skeletal-muscular complaints like osteoporosis, osteoarthritis, muscle weakness. So we have to ask all these details in the history. Now the next comes examination. What we have to include in this the height, weight, waist circumference. Normally we say that waist circumference should be less than around 85 centimeters, and calculate the BMI accordingly. Next important is a pulse, BP, her systemic examination like cardiovascular examination, respiratory system examination, CNS examination, eye examination for degenerative changes, breast examination, and the pelvic examination. Now in the screening, what test we should advise the women of the menopause age or perimenopause age? This important investigations like CBP, ESR, thyroid, TSH, lipid profile, serum calcium, serum vitamin D3, alkaline phosphatase, serum albumin, serum creatinine, PTH, stool for occult belt. FSH normally we don't recommend for the diagnosis of the menopause. Eye checkup is mandatory, ultrasonography, pap smear and HPV DNA test, that is a co-testing. Nowadays we advise co-testing so we can repeat it after 1 year to 3 years of gap. Mammogram to be advised after age of 40 years and it is to be repeated every 1 to 3 years depends upon her symptoms. The next important advice about the DEXA scan to know the status of the bone health, especially for the diagnosis of the osteoporosis. Here we use the T-score to know the status of the bone health. Here, when the T-score is -1, we say it's a normal. Osteopenia is the score, T-score between -1 to -2.5. Here some mistakes are there. Please forgive us for that. Osteoporosis is diagnosed when the T-score is -2.5 and severe osteoporosis we diagnose when the T-score is more than -2.5. DEXA scan is to be done for the lumbar spine, hip bone. These are the commonest signs, but that can be done in wrist, humerus, radius, and rib also. It is to be repeated almost every 1 to 5 years or 2 to 5 years on the same machine. The important thing that calcium to be stopped before DEXA scan. Now about the management. Already we have discussed about the dietary and the exercise. The most important is the hormone therapy to decide upon her symptoms associated with the comorbid conditions and the investigation findings. And after counseling and after explaining her, we have to decide about the hormone therapy. Here the menopause hormone therapy having different regimes like low dose combined oral contraceptive pills. It is specially used in the menopause transition and premature ovarian failure. It is to be continued till the age of the menopause. The second regime is only estrogen. It is to be prescribed in hysterectomized patients or with the patient without the uterus. The third most common regime is estrogen plus progesterone. In this regime is we advise normally in the patients with the intact uterus or patients has undergone subtotal hysterectomy where cervix has been there, or patient with hysterectomy with history of endometriosis. The commonly used regimes are conjugated equine estrogen, that is the Premarin 0.625 along with the medroxyprogesterone acetate MPA 2.5 milligram. Other combination we can use is CEA, that is the Premarin with the norethistyrone 1 to 5 milligram. Third most commonly used combination is a C with a micronized progesterone and a C with dihydrogesterone. It can be used cyclically or sequentially or in continuous combined way. Estradiol value 2 milligram also can be used. Another route of the or non-oral route of the estrogen administration is transdermal estrogen. Here in India, the transdermal estrogen is available in the form of gel or cream, Astrobet cream. It can be combined with dihydrogesterone and decreases the risks of the CVA and the thromboembolism. The non-oral estrogen, that is the transdermal estrogen, is indicated in patients where the increased triglycerides, where we cannot give the oral estrogen, the increased CRP, the patient suffering with the migraine, diabetes, controlled hypertension, and existing gallbladder diseases. Even in obese patient, we can prescribe transdermal estrogen. Another route of estrogen application is transvaginal estrogen application that is specially used for genitourinary symptoms to get relief of genitourinary symptoms. Now, other supplementation which we have to give along with the hormone therapy is a calcium, vitamin D. Already we have discussed these two things. Now, third most important is a bisphosphonates in osteoporosis. Commonly, we are using alendronate 70 milligram per week for 3 to 5 years, and drug-free period is to be considered after that. The most important advice or precaution we have to explain to patient that to sit upright position for 1 hour after the alendronate. Zoledronic acid also can be given 5 milligram infusion over a 15 minutes once in a year. Another form of treatment is a complementary alternative therapy, that is herbal treatment. Whenever patient is not fit for hormone therapy, it is contraindicated. Hormone therapy is contraindicated in that patient. Patient refuses the hormone therapy because of some fear or maybe some other reason. That time we have to treat her menopause symptoms like vasomotor symptoms by prescribing the herbal medications, which also gives the equally good results. Now, what are the contraindication of hormone therapy? The active endometrial diseases or breast cancers, undiagnosed uterine bleeding, severe liver diseases, history of venous thromboembolism, and SLE. Relative contraindication for hormone therapy are migraine, thrombophlebitis, family history of CA breast, uterine fibroids, endometriosis, gallbladder diseases. Now patient is on hormone therapy. When we have to stop hormone therapy? Whenever patient is suffering with the migraine and it's worsening. The second important, jaundice. Patient is suffering with the jaundice. The third important point, when BP is increasing. And fourth important point, when patient is unplanned any surgery. So minimum 4 to 6 weeks prior to surgery, the hormone therapy should be stopped. And now the COVID infection is also another reason where we have to stop the hormone therapy. Oral hormone therapy, though the transdermal, they say it's safe. In fact, it's advised in the COVID infection. Still, research is going on. So, what is the duration of hormone therapy? It can be safely given for 3 to 5 years, but the patient needs annual visits, annual counseling, annual checkups, and maximum it can be given up to 7 years, and but not beyond age of 60 years. So, this is all about menopause management. Thank you very much for patient hearing. And I congratulate Shield Connect and the team for creating this platform for medical education and updation. Thank you very much for patient hearing.
Thank you very much, ma'am, for your excellent and superlative talk. It is always an honor and learning to hear you, ma'am.
Thank you.
From the presentation, I understood that no menopausal symptom is universal. There are many options for the treatment, although opinions are still polarized.
Yeah.
Advice on its use has changed after the Women's Health Initiative studies.
Yeah.
So, if you allow me, then, ma'am, we'll have a question and answers from questions from the delegates.
Okay. Okay.
And we have a first question. Hello.
Yeah, please.
Yeah, whether genitourinary syndrome is underdiagnosed and undertreated.
Yeah, definitely. Why? Because the women of menopause age or any women is shy of sharing her sexual problems with any other person or even with the doctors also. In that case, we have to ask the leading questions to the patient, especially asking, do you have any problems with the sexual activity? Do you have any itching, irritation, dryness? And then they start, yeah, madam, this is happening to me. So we have to ask leading questions to know their problems. That is really happening in our day-to-day practice.
Thank you, ma'am.
And the urogenital symptoms are very well, and especially the recurrent UTI. In the menopause, there are the urinary symptoms like urgency, frequency, recurrent UTI, and they are many times we treat very repeatedly, but again they are suffering. In that case, the local estrogen application every night for 15 nights, followed by twice a week, up to 3 months or maximum up to 1 year also can be prescribed. And patient is coming back after 1 or 2 months, madam, really we are very much happy with this sort of treatment because of this local vaginal application of estrogen. We are prescribing different estrogen creams like Evalon creams and all. They are very freely available in the market. For the transdermal estrogen applications, we are advising Estrobet, that is also freely available in market. But patches are, I'm not very sure. Even vaginal estrogen rings are also, I'm not very sure. But the creams and ointments are very freely available in the market.
Thank you very much, ma'am. There is a appreciation message from Dr. Saumitra saying very good lecture.
Thank you very much.
Ma'am, I don't find any questions from the delegates. So if you allow me, then we will close this webinar.
Yeah, thank you very much for this opportunity, and I really congratulate you once again for this wonderful program.
Thank you very much, ma'am.
Madam, really thank you so much. The way detailedly, nicely you taken up, it was really, everybody would do, it will be useful to everyone. We'll continue to connect, madam. Thanks for doing that.
Yeah. Okay, thank you.
Thank you very much, madam.
Thank you.
On behalf of Shield.
Thank you, ma'am. And I also thank all the delegates who are participating in this webinar. And thank you very much. Have a good day.
In this topic, YouTube లో మీరు చూడొచ్చు, మీ ఫోన్లో యూట్యూబ్